Welcome everyone. Just want to provide a little bit of a background and set the scene for some of the things that we're going to be saying and maybe some of the discussion we may have along the way about this whole issue of weight. And I guess, coming to it from a psychological point of view, as a clinical psychologist, my background and my lens is one of mental health. But the reality is that, obesity is just so common among those with mental illness, and chronic illness of other sorts is also very common among the mentally ill. And it was pretty early on in the process of working in mental health that I began to realise that these things are interrelated. Weight gain is actually a diagnostic symptom of mood disorders. If the DSM regards fluctuations in weight, both weight gain and weight loss, as diagnostically indicative of the presence of a mood disorder. And there are other illnesses as well that you might look at weight gain as a diagnostic indicator for those sorts of things. But, the correlation that might be there doesn't necessarily imply an obvious causation. Sometimes you'll find that, that a depression is leading through coping behaviours is leading to weight gain. It may be that some of the medications that are being prescribed is leading to weight gain. But then you may get someone who has a chronic metabolic disorder, who's gained a lot of weight, who's then developed depressive illness in reaction to that. But the research points pretty clearly to, a correlation between chronic illness, chronic mental illness, and obesity. The rates of obesity in people with schizophrenia, schizoaffective disorder, major depressive disorder, and bipolar disorder, for example, are nearly double that observed in the general population. So we've got that correlation there, but what we need to do, and what I'm going to kind of talk about, hopefully we can talk together about, Georgia, tonight, is how to pull that correlation apart and understand the causation, understand the etiology, and really get to the point where you can look at it on a case-by-case basis. And I think that's really essential, because if you're going to engage with a patient around their weight, then you need to be able to engage with that individual patient at an individual level on the basis of their individual experience and attributions around their weight. There are some psychiatric disorders that are pretty explicitly linked to weight, such as eating disorders, and there has been different schools of thought about the interactions between these things. When it comes to eating disorders and obesity, they sometimes can be lumped together. I know of some, for example, some psychology clinics that will simply kind of do a catch-all. They'll work with all eating disorders and obesity together. But my view has always been that they need to be regarded very separately. I think that eating disorders are not primarily actually about eating. They're about anxiety or family issues, personality issues, emotional problems that are being expressed through disordered eating. So to equate eating disorder with eating is, I guess, a bit like equating self-harm to poor knife technique. It's kind of thinking about things a bit too concretely. But we do sometimes do that with weight and with eating-related behaviours. We tend to just look at what's in front of us and not look behind it. As psychologists, we're trained to look behind what's in front of us and try to understand the causes and to look at the individual that's carrying those issues in order to tackle them. But the sort of take-home message here is that it's really crucial to assess and identify what's the primary problem here. Is the primary problem weight gain from unhealthy habits? Or, as we are increasingly seeing, is the weight gain secondary to an underlying primary issue of metabolic disorder, psychiatric disorder, medication side effect, steroid use, some other kind of factor that is driving this weight gain? And depending on what's going on behind this weight gain and what's underpinning the behaviour, there is really potentially quite a different treatment approach that you would need to use. But regardless, as we'll discuss, weight control is a long-term problem that requires a long-term solution, and most importantly, the patient, him or herself, must take the lead in driving that solution and maintaining it. And that's what some of the slides we're going to be going through tonight, some of the issues we're going to be talking about tonight. That's what's going to be the core message there, I suppose.
Thanks, Cal. So let's have a look at what we as general practitioners are doing, or rather, embarrassingly, what we're not doing. As you may be aware, the Beach Data report from last year looked at general practice activity in Australia between 2015 to 2016 and compared the general practice activity to about a decade before. And as we can see in the red circle and the arrow down the bottom there, obesity being defined as a BMI of over 30, we've seen that less than 1%, yes, you heard me right, less than 1% of consultations that have been held in general practice centre around the issue of obesity. And this is in the background that we know that 2/3 of Australian adults have overweight or obesity, and 1 in 4 school-age kids have overweight or obesity. So obviously as GPs, we're not doing enough. However, that Beach study only looked at those with a BMI of over 30. I'd actually like to, encourage anyone who has been in general practice more than 10 years to actually send me a message now and tell me if they have any patients who, or I should say, do they have many patients who actually started off as overweight and remained overweight without any intervention. I dare you. The reason is, and I hope I'll probably get the odd person, and there will be the outliers, but the reality is those of us who've been in clinical practice for more than 10 years will agree that people who have overweight are likely to develop obesity as the time goes on. They always tend to find themselves on a weight gain trajectory. That's the majority of patients. There will be the odd outliers. And
Georgia, if I could just add there, I think that for the patient themselves, they'll be very sensitive to their appearance even before they reach a point where they're clinically obese.
I totally agree. Yeah. And that's important. And I suppose that's a main important message that I want to get to this slide. I just don't want us to forget those that have got overweight, because for this slide, for me, really highlights a couple of important things. Firstly, patients who have overweight, meaning BMI above 25, will start to experience an increase in morbidity and mortality. And we can see once they've hit a BMI in the class 3 obesity range, so BMI over 40, the hazard ratio is 2, and therefore their risk of increased mortality and morbidity goes up significantly. And on average, the studies are predicting that patients with class 3 obesity, i.e. BMI over 40, are basically shaving off about 10 years off their life expectancy. And so I just want us to be cognizant of the fact that we shouldn't forget those that have overweight. And let's remember, in this study here that looked at more than 239 prospective studies, we saw that these patients had a BMI of over 30, however, they'd never smoked and they had no pre-existing conditions. And so they eliminated all the other factors that might be contributing. And so we're seeing generally by the fact that they are carrying excess weight is detrimental to their health and longevity. And like you said, from a psychological point of view, this happens early on in the piece.
The issue becomes a real issue for them, usually, before it's become a clinical issue as well.
I totally agree. And I think that's a nice segue into my next point. Just like we can't tell who has high blood pressure when we're just looking at them in the waiting room, we need to actually sit them down and measure them. Similarly, we can't tell those who've got overweight or class 1 obesity simply by looking at them. Admittedly, yes, it is easy to recognise someone who's got class 2 or 3 obesity, but even then, we can't tell how sick they are and whether they have any psychological or physical ailments as a result, and it's a complication of their obesity. For me, adiposity is like real estate. It's all about location, location, location. And I'm sure Melbourne and the other major capital cities are similar to Sydney, where I'm originally from. Generally, real estate in the CBD tends to be expensive, and then in the suburbs is a bit more manageable. With respect to adiposity, we know that adipose that's centrally located is associated with increased risk of heart disease, type 2 diabetes, some cancers, many detrimental aspects of their health. Whereas the studies actually suggest that that fat that is peripherally, mainly on the buttocks and the thighs, is actually cardioprotective. And so this is something that we've known for many years. I remember being a teenager and looking at Dolly and those kind of teenage magazines, and we already knew back then that the apple was unhealthy and the pear-shaped person was healthier, but we didn't understand why. But now we actually know the science behind it, that the fat cells that are around the central area, the visceral fat, actually produces hormones and chemicals that are actually cardiotoxic, produce inflammation, whereas the fat cells that are stored in our buttocks and thigh area are actually cardioprotective because they produce chemicals and other elements that are actually good for us. So when and I'm not being sexist, but generally when my females come in and say, I want to lose my butt and thighs, and I go, you should embrace them because that's the reason we outlive the men. Yeah. But getting on to more serious points, I just wanted to illustrate the point that we really need to get our tape measure out, measure their waist circumference so we can get an idea of whether they're at the high risk or high risk for metabolic health conditions or not, and similarly hop them on the scale, measure their height with a stadiometer to work out where they are in the classifications. And I just want to highlight, and it's readily available, these numbers that you see on the screen are for Caucasian people. Obviously for certain ethnic subgroups, the BMI levels are actually reduced, in particular for those from South Asia and China. And if you'd like to find out more, you can see the NHMRC 2013 guidelines. There's a nice short summary for GPs. In 2015, Turner and colleagues published the results from a retrospective analysis of more than 270,000 adults looking at their medical records, and they did so via a Melbourne GP-based database. And embarrassingly, they found that only 22% of patients had a BMI documented and only 4% had their waist circumference documented. This is quite embarrassing. Now, on a positive note, the patients that were most likely to have these parameters documented were the elderly, those with type 2 diabetes, with hypertension and hyperlipidemia. So that's a good thing. However, women were less likely to actually have this documented, and they actually represent the majority of the patients who've got clinically severe obesity. And so my take-home message from this slide is we need to measure, because if we don't measure, then we're not identifying the patients that need treating. And so we definitely need to do more. Let's not forget that the RSAGP Red Book, by which we all are guided by and also at times of need are judged and compared to our peers, clearly advises that as health professionals, best practice is that we should be calculating a BMI every 2 years in all our patients. And in subgroups such as those with type 2 diabetes, cardiovascular disease, stroke, liver disease, or those from high-risk groups such as those of Aboriginal, Torres Strait Islander background, etc., we should be doing it annually. And that's still not enough. Once we identify those that do have overweight or obesity, we should be putting in our IT systems recall so we can get them back in 6 months. Because as I said earlier, many of them find themselves on a weight gain trajectory. Now, you could easily ask yourself, Cal, why should GPs bother talking to their patients about their weight? For many years, GPs that I've spoken to have said, oh man, I just don't want to go there, it's too hard basket. But the literature tells us that many patients not only want, but they actually expect weight loss guidance from their healthcare professionals. Secondly, the literature tells us that when a healthcare professional has a conversation with their patient, and that includes making a formal diagnosis of this medical condition and documenting it in the notes and putting in a treatment plan in place, then the patient is more likely to lose the weight and to also improve their health. So I'd like to now pass over.
Just before we leave that slide, I just wanted to make a couple of other observations about that.
Thanks, Cal.
And I would, George has already put the invitation out there to ask questions, make comments. I'd be particularly interested, if as we go along, if some reflections from your practice spring to mind about what makes it difficult to raise this topic with patients. It's interesting, when I was looking at some of these slides as we were preparing it, I found myself thinking, it seems like so much treatment here is symptom driven. And maybe there's nothing wrong with that really, but what we're talking about here might often look like talking to a patient about something that isn't the presenting problem. And it's sort of about broadening out the scope of the consult. But how do you do that, and why would you do that? Obviously, there's some, literature evidence there on this slide to talk about that. But I would, at a more kind of pragmatic level, I would say that isolation in a patient, in an individual, it creates inertia for any individual. And weight, particularly once shame starts to kick in, weight becomes an isolated issue. It gets isolated. It doesn't get talked about. It doesn't get talked about by the patient. It doesn't get talked about by the patient's family. It becomes a taboo subject. And that really just locks in behavioural inertia around that problem. So just talking about the issue, just that, not even at the point where the conversation would lead to action just yet, but just talking about the patient reduces the isolation. It reduces the isolation of the patient, and it reduces the isolation of the issue. And it sets the scene for changes to occur, whether that's intentionally or just spontaneously. So this is, I guess, kind of axiomatic for psychology, but it does seem to me, as I talk to medical practitioners, that whole question about how do we get the light bulb to want to change? Change itself is rarely the goal for when a psychologist is working with a patient, but rather the goal is to set the scene wherein change can occur. So I'd be very interested if any of you can, put finger to key about, what are some of the obstacles that you're encountering in the consulting room that are making it difficult either to broach the subject, or if you are, if it is a live issue and that there is a discussion going on, what are some of the obstacles to change that you're seeing there? Maybe it's just a question of time. Maybe it's patient attitudes. Maybe it's about the scope of the consults. Maybe there are systemic issues there around, the healthcare system and the length of a standard consultation. I'm not sure. Maybe there's something there about retaining and maintaining continuity across consults. But we are going to touch on some of these issues in the slides to come. All right. So I thought really to kick it off, I might just talk about some of the, factors, some of the elements that, a therapist or a person whose area of work is primarily about engaging the patient in a constructive relationship that is the setting within which change can occur. What are some of the elements there? And it's like baking a cake, and these are the ingredients, I guess, recognizing that, cakes need time to rise. And these are roughly in chronological order as well. So as things move along, you might move on from one of these elements more and more into the next and the next. But initially, just taking a position of curiosity. Curiosity about the patient might seem like an obvious thing, but what I really mean by this is an openness to the patient's experience and their point of view. Being open to their ideas and their attributions about their own health and well-being. It doesn't mean that your ideas or evidence-based medicine will be eclipsed or kind of displaced by that. But if you allow the patient to feel that there is room for their mind and their point of view, then I guess that allows it allows for two things. The first thing it allows for is for a dialogue to start, and that is part of the setting for any change to occur, is that there is a discussion, there's a discourse around it. But the other thing that it does is it puts the spotlight on the patient. It's like handing the patient the microphone and saying, well, why don't you talk about your health for a second? I'm really interested to know what's your position on all of this. And if you do it genuinely, from a genuinely curious point of view, you'd be surprised some of the things that patients will feel comfortable to come out and say. And that information is absolutely invaluable if you're then trying to formulate a bit of a plan of action with this person. And it doesn't have to take a long time either. It can be one question. Once you've got a bit of an open discussion going, I think it's important to maintain compassion. And I guess that's pretty self-explanatory, but sometimes that can be hard to offer, of course, in the context of a busy practice. It can also be hard to offer when you've got a very resistant or a very kind of defended or kind of hostile person who, is really not wanting to talk about anything other than the presenting issue. And that's fine, but I guess it's at those times where the compassion becomes particularly salient. Continuity is crucial, given that you're likely to see the patient more than once. I would hope that you're going to see the patient more than once, because this is a chronic issue that we're working with. A therapeutic relationship is going to take repeated consults to develop, whether they're short consults or long consults. A simple means of maintaining continuity for the patient might just be to make mention of something that came up at the previous consult, whether it be a clinical or personal in nature. It's like, oh, you've changed your hair. Just anything that makes them kind of suddenly realise that you are paying attention and you do remember the last consult, whether they do or not. But again, it's sort of tangibly demonstrating to a patient who may not realise that you are really watching and thinking. It shows them that you remember who they are and you remember what they're struggling with. Confidence. This is an updated term to what might until recently have been referred to as authority or reassurance. The aim here is to treat the patient as a peer and a collaborator rather than a subject. This has the advantage of vesting in the patient more responsibility for their treatment than might be the case in a more hierarchical interaction. And again, with chronic illness, you've got they've got a long road to travel, and sort of basically engaging with that person confidently and showing that you're confident in them and their capacity, even if they're not, it signals to them that they have a really legitimate part to play in this process, and they're going to need to see themselves in that way if they're going to be taking up the cudgel of making things change for themselves. The last thing in there I put in creativity, which might seem like we're starting to get into, really the realms of touchy-feely stuff. But fundamentally, I'm putting it in there because it's actually a diagnostic indicator for a good therapeutic relationship. If there is humour, if there are new ideas, new outcomes, new things emerging from the consult, from the discussion, if something new pops up, then that is what I would refer to as creativity. Something new has been generated from the process. And if you say, gee, you've changed your hair, and then they come in, at the consult after that, and they say, well, I've actually decided to do this and take more care in my appearance, that's something new that's emerged from that process. And if you're wondering whether you're making any difference at all, then that's a useful kind of indicator that something's really starting to happen. I can see Georgia typing away there to some of the questions. I'm just wondering if there's anything that's come up from that previous slide that's worth making a response to more generally.
I suppose one that's caught my eye is, and I'd be curious to hear what your thoughts are, Cal. I'll just quote the gist of it. There's a normalisation of high BMI in society in many places. Overweight patients often state that they feel, inverted commas, normal, and they resent the implication that they're unhealthy. Or they'll say something like, oh, I'm overweight, but I'm not unhealthy.
Yeah. Yeah. Well, it's interesting. We're going to do. I've actually prepared a couple of case examples that we'll talk to. That, I mean, it's nice coincidence there that, you know, I see that as well. Even to the point where there'll be patients who will talk about body pride, and hey, you know, that can be a bit of a tricky one, I guess, because what you want to do is you don't want to invalidate the patient's perception. But at the same time, there are some real issues here that need to be broached. So yeah, let's move along so we can start to talk about some of those things. So I just wanted to talk a bit about and kind of acknowledge that, and invite you to remember that, you know, that you're there with a view of the patient and their health and the reasons for their poor health. And the patient will have their own view, and I guess this is going to perhaps some of the comments that are coming through. You know, how do you kind of bridge that gap? You'll have your own formulation, and, you know, it may not be self-evident to the patient, and it may not align with the patient's ideas about their own condition. I think it's important to allow those two perceptions, those 2 points of view, to coexist, at least to begin with. You know, we'll break this down shortly, but I guess it's important to make room for the patient's point of view as a starting point, because that's actually going to give you something that you can work with. What I wanted to introduce with this slide is also, when we're talking about the patient's attribution, and when you're looking at it and learning about it from the patient, when they're answering your question about, so how do you see this issue, you will get a sense of what we call locus of control. So is this patient regarding themselves as the agent of change and the kind of primary controller of the events and circumstances of their life? Or are they seeing themselves as kind of the person who is kind of at the mercy of their circumstances? Is their locus of control internal, or is it external? If they're going to control their weight, then they're going to, that's going to require the active and ongoing efforts of the patient, and that requires that they see themselves, and not you, as the agent of change, fundamentally, primarily. And so that's really the first thing, if we're going to talk about assessment and breaking down that question of what's this weight really about, one of the things we're really looking at first and foremost is how does this patient see the responsibility for their weight and the responsibility for it changing? And if they see that as external, then nothing is going to happen until that we start to tackle that. I thought it might also just briefly be timely to mention some formal assessment that, you know, if there is the thought there that there is a comorbid psychiatric condition, and even if you're not sure, if you have an overweight patient, there's a very high likelihood that there are some comorbid psychiatric disorders going on. And I encourage, when I work with clinicians, I encourage them to assess mental health alongside physical health, because quite often mental health is a useful indicator of progress as well. I've done some of my own research on this, for example, among bariatric surgery patients. More than half of the bariatric surgery patients who I see in a clinic in the inner west will meet criteria for depression. Within about 6 to 9 months of having had their procedure and lost some of their excess body weight, that depression has pretty much remitted. And the way we're assessing that is using some of these formal tools. Most of the time when a GP sends me a patient, they've administered the K10. I want to sort of just mention here that the K10 is not really an assessment tool, despite what others may have said. It's a research tool. So I guess it's like the difference between a medical thermometer and a meat thermometer. They both measure temperature, but they're actually for slightly different purposes. I'd encourage you to use the DAS-21 or even the DAS-42. It's free. It's The patient, it's self-administered. They can be given a copy of it in the waiting room. It's very quick and easy to score, and it'll sit there alongside some of your other clinical data. You barely have to lift a finger, but it gives you some very rich information about the patient and their general quality of life. And let's face it, the Venn diagram of those two circles of quality of life and weight-related health, that there's a lot of overlap there. Moving right along. What else might we assess here? Well, we're assessing readiness. Readiness to talk and readiness to do something about the issue that you can see and that you've measured, both with your tape measure and perhaps with your psychiatric mental health measure. It might be that even if this patient is, an older person, it may be the first time they've ever discussed their weight, or it may be the first time in a long-term time that they've discussed their weight with anyone. Remember that weight, an issue of shame, tends to be an issue that becomes isolated. They may not be familiar with the negative impacts of an unhealthy weight. In such cases, just discussing some of these adverse health aspects of obesity and how obesity might affect their quality of life can be valuable. And that's all it is a discussion. For some people, past experiences have been criticised or blamed for their weight, either by peers or family members or even by some healthcare providers. It might make them reluctant to discuss their weight. Curiosity is the starting point. Curiosity about their experience, about their attitudes, about their expectations. You'll be surprised how far you'll get just by asking some fairly open and sort of non-solution focused questions. So what I wanted to do, and also just with some of these comments that are coming through in mind, is I wanted to give a couple of case examples. These are based, obviously, completely de-identified, but they're based on a couple of fairly typical people that I see, both, in hospital and outpatient settings, and sometimes in my own clinic, where people are coming in for longer consults on an ongoing basis. The first case example we've got, Georgia, do you want to run through?
Sure, thanks, Cal. So, and these are very common case scenarios, so they're not far-fetched. They're actually patients that Cal and I have seen in clinical practice, and I'm sure many of you here this evening can relate to. So we'll start with Steve, a 45-year-old gentleman who works as a tradesman, and alcohol is a key factor in central adiposity in his particular circumstances. There's or I'll be stereotypical, the ethos of you finish a hard day's labour and we have a few pints at the end of the day at the local pub, and a few more on a Friday or Saturday night. His ears come in complaining of headaches. His wife says he snores and she's getting fed up about that. We've measured his BMI, 39. We didn't document the waist circumference here, but it was measured, and he was high risk metabolic health disease. But as is often the case, and this is just an observation, not a gender statement, very rarely do males come in to see a doctor willingly. Often they're dragged by their partner, or because another specialist has demanded them to come in and see the doctor. So how would you broach this one, Cal?
Well, I guess there's a few things here. Even though it's a very, very thumbnail sketch of a case, I would imagine that this is the kind of patient that many of you have clapped eyes on. Steve needs to lose weight. That's unambiguously the case. His comorbidities are not going to meaningfully improve otherwise. And his obesity has what I would think is some pretty obvious etiology, which means that I think even though Steve is a pretty rough and ready blokey bloke, it's probably on some level pretty obvious to Steve that he's not in a good state of health and that his weight is a factor. But does he actually see it that way, and is he going to acknowledge it to you in the room? He's basically sort of trying to sidestep the whole issue by saying, well, look, I'm just here because my wife says I snore and she says I need to come in and see you. And I think that's actually really important, is to find out, well, why are you actually here, Steve? You know, not just medically, why are you here, but personally, how long have these headaches been going on? Oh, okay, they've been going on for a year or 2 or 4. So why are you in here now? Are you in here now because your wife has sort of started to add to your headaches? Are you in here now because, you know, you found that you got short of breath when you were walking up the steps to the pub the other day? What is it that's happened to you personally? His comment about his wife would suggest maybe there's an external locus of control, using that jargon again. Maybe he's just going to go along with what others say and not see himself as the agent of change. So is he only coming in to see you to get his wife off his back? Or is he here because he himself has something that he wants to work on? And I think the key then is to work out what exactly is that. Is the headaches the thing that's really bothering him? What can we do about the headaches? Even if there are more glaring things happening like the central adiposity, if the headaches is the thing that matters to him, then the headache is the thing that's going to get him moving. Patient-centered language means using what the patient brings you. If Steve is here because of his wife, use that. Steve, is your wife worried about your weight as well? Or is she just worried about your snoring? We need to move as soon as we can, though, to locating Steve at the centre of the discussion and at the centre of things. So ask him, Steve, what is it that you're looking for here? Now, later on, I'm going to talk a bit about stages of readiness. And it might be that Steve is, you know, at a pretty early stage, you know, a pre-contemplative or a contemplative stage. He may not be in the frame of mind to be taking on any really big new challenges at the moment. But if he makes a comment along the lines of, I'm just here to get my wife off my back, well, then your goal there is going to be pretty clear. I think your goal is just to keep in touch with Steve. It's just to maintain a connection with Steve. And make sure that that isolation of the problem and that kind of insulation of the problem, that's sort of prevented and addressed as a first issue. But if Steve identifies something that he himself wishes to change, like his sleeping, or if he says, oh, look, I probably should try and work out how to drink a bit less, or some other symptom, then you can link that back to your weight and you can make a plan. So making Steve the agent of change means putting him squarely at the head of the treatment team, I like to say. Steve, what would you like to see changing here? Do you want to sleep better? Okay, great. So do you have any ideas about how you would achieve that? I want to hear how you think you could do that. First, I'd like to help and I've got some ideas, but I want to know what you have in mind first because, you're the boss here. So that's some of the thoughts I have about Steve. Please, contribute your thoughts as we go along.
Thank you. Thanks for that. And then what about the next one? So Dorianne, a 21-year-old hairdresser who's come in with dysmenorrhea. Her BMI is 34, waist circumference was about 102 centimetres, so she's high risk. And she spontaneously mentions weight. But she also talks about what you've termed thick body pride, and I'm sure you'll unpack. So basically, in some cultures, big is beautiful. Big is equated to being healthy. I was actually surprised. A few months ago, I was giving a talk, and a GP spoke to me during one of the breaks, and she said to me, "Look, I'm from Ethiopian background, and in our cultural group, people who are overweight is basically the sign to the community saying, I'm healthy, I don't have HIV, I don't have TB. And so that's a sign of good health and prosperity. So how do we tackle that one? Because that's a tricky one.
Yeah. So Dorianne's referring to weight in the context of pride. She's definitely what I would say pre-contemplative about losing weight. But on the plus side, she seems to have a degree of, well, from this, it seems like she's got a degree of self-worth and a sense of kind of personal agency. You know, if she's genuinely proud of herself, then that's actually terrific, you know. And it's going to come in handy if we want her to take the lead in her own health and her own self-care. Now, I have seen a few patients like this, male and female, usually younger, who will come in and they'll say, well, you know, I like being big. Big is beautiful. And sometimes, you know, it's kind of what you see is what you get, but sometimes there's bravado there. So it is worth, again, coming back to this notion of kind of understanding what's going on behind the presentation, making sure that her comments aren't just bravado. Now, a simple way to do that is just a really brief, what I'd call like a validating discussion, just, again, being curious about her body pride. Oh, okay, so, is she secretly ashamed, or is the pride a fervently, genuinely held belief? So, I've just wrote down a possible question here. It's like, Dorian, look, I'm a bit older than you, so I confess I'm new to this whole concept of thick body pride. Can you tell me a bit more about it? Like, it's what a colleague of mine calls the Columbo technique. It's like, I'm just trying to understand here, what's actually going on? Can you just show me what is this body pride? I want to understand. I'm a bit older than you. Just sort of, just almost like taking a naive position. Now, you might find fairly quickly that she just wants to change the subject, in which case it's not actually a matter of pride. Or she may be quite enthusiastically then go in and show you the Facebook page and want to talk all about it. Either that then, I guess, determines the pathway that you're going to go on. I think either way, though, she's unlikely to be interested in losing weight, at least at this consult. It doesn't mean that the topic is off limits, though. I really need to stress that. Just because they don't want to talk about weight doesn't mean that you're not allowed to talk about it. It's still respectful to take an agree to disagree stance. For example, Dorian, I can tell that you're proud of your body, and that's great to see. Your body is a temple, and it should be cherished. Now, it will probably come as no surprise to you, Dorian, that I have my own opinions about what a healthy body looks like. And, you're probably not surprised to hear that I have a bit of a different view about your weight and about your body when it comes to your longer-term health. Now, I don't want to change who you are, and I'm not going to be bossing you about here, but I also want you to respect my take on things, like I respect yours. So I want to ask something here, Dorian. I want us to keep in touch over time so I can make sure that you can stay as healthy as possible at this weight range that you've chosen to be at. So can we plan to catch up, say, I don't know, twice a year for a checkup, even if you're feeling good? Because, to have a body that you can be proud of, it also means a body that you need to keep in shape and keep healthy. That way I can help you take care of this lifelong asset. Now, these are my words, and obviously you're going to have your own version of that. But I guess the key point I'm trying to make here is that you're putting your position alongside theirs. Being respectful doesn't mean being differential. It means basically we're all equals in this room here. You've got your take on things, I've got my take on things, and we're going to have a conversation that makes room for both of those things. Now, Georgia, I think you've got some thoughts here about patient engagement as well.
Yes, I do. Thanks, Cal. And I suppose looking at it from a chronic health condition point of view, we know that if we have the patient engaged and involved in their own care, then it will see an improvement in their own healthcare outcomes, but also they take ownership and they feel empowered. They don't feel as if they're a victim and that they're helpless. They're actually feeling empowered and able to do things. We've seen this illustrated quite nicely in this diagram here on the screen. We've seen that successfully achieved in the diabetes space, where over the course of several years we've now developed expert patients who help to promote good self-support, but also who can actually self-manage both their symptoms, their medications, and also what to do in a time of crisis. And so, from my point of view, setting goals and a management plan with the patient really requires buy-in from the patient. And this is not going to happen in one consultation. It will take a couple of consultations, and that's okay. Rome wasn't built in a day.
Yeah.
So we have, as you said earlier, it's a lifelong commitment. This is a chronic progressive health condition, just like diabetes and asthma and other health conditions. So chip away at it, slowly at a time.
And like even if their weight changes, even if their health improves and some of those chronic symptoms remit, that doesn't mean it's over. This is something that they're going to have a relationship with one way or another lifelong, and ideally, therefore, you're going to have a long-term relationship with them and their process as well. Yeah. It's taking that long view, which is a good thing, because it means there's time. There's time to continue going through problems, not just get bogged down in them.
Thanks, Cal. Over to you.
Look, the other thing I just wanted, and again, this is something that is just developing that idea of how you're engaging in the consult, particularly if you have the opportunity to have a longer consult, if you're developing a chronic disease management plan or something like that, for example. Shame, as I've mentioned shame before and the isolating effect of it, it's a sensitive issue to discuss. There is different schools of thought on this as well, but my view is it's really important not to reinforce shame by tiptoeing around an issue or going softly. That's what I mean when I talk about confidence. You need to, if you have an opinion, then you need to state it, and and it's not stigmatizing to state it frankly. If you're direct and you're compassionate and you're empathic, then the patient will respond to that. They'll follow that cue. I don't want to tiptoe around this, Susan. I'm wondering what you think about your weight and if it's been put in the too hard basket. I'm coming from a compassionate point of view. I'm here to help. There's empathy there, and empathy with the struggle. It's not about trying to get to a solution. It's first about recognizing the problem and recognizing the patient's experience, and that gets them on board, and then moving them into the frame. We'll acknowledge the problems, and then we can start talking about solutions. And those solutions, ideally, are solutions that first come from the patient. It's also important to broaden it out and recognise the overlap. That weight isn't something that generally happens in isolation any more than other chronic health conditions. And so we broaden it out and talk about, these broader issues. There is a couple of even some other phrases that I've jotted down here. We don't want to put people on the defensive. We don't want to make them feel like a failure. You could say something like, Mr. Jones, it's nice to see you today. I see your blood pressure is a little high. Now, there's a connection between those two. There's a connection between your weight and your blood pressure. But one of those things, the extra weight, is in our power to do something about. So if you're broadening it out, then that's another way of kind of destigmatizing the issue around weight. Okay. Georgia, is there anything you wanted to add to that, or is that?
No, I think that's a lovely segue to the next slide. And remember, my apologies. I got too happy, my apologies. So essentially, I just wanted to firstly start by saying to everyone here, and I'm sure we agree, Cal, that weight and health are related, but they're not necessarily the same thing.
Yeah.
Okay? So when I talk to patients for any chronic health condition, our goals are to improve the quality of life, to improve their function, their day-to-day function. Can they bend over and pick up their keys off the floor? Can they run after their grandkids or their kids? Can they go on an aeroplane to Queensland to take the kids to SeaWorld? To reduce end organ damage, to reduce morbidity and mortality. And as we said earlier, engaging the patient is critical. But the key points that we're going to be unpacking further are that the aim is not weight loss, it's an improvement in their health. Yeah.
So, Georgia, you said earlier on that it may not be immediately obvious just looking at the patient to get a sense of, how obese they might be, what category they might fall into. And I guess the same thing goes for the patient. It may not be that the things that stand out the most to you are what stand out most to them. I've had patients nominate all kinds of weird and wonderful, very specific, sometimes quite niche things as the things that really they care about the most when it comes to their weight. I mean, you mentioned travelling to Queensland. Aeroplane seating is a big one. It's a really, really big one. And it's amazing how I've had patients who will flat out say, I don't even really mind if my lifespan is shortened. I've had a pretty good life, but I do want to be able to go and see my grandkids in Queensland, and I just can't do it because I can't make the trip. And that's what I really want to be able to do. And it seems almost crazy that they would be more concerned about a very simple practical thing than they would be about, their, more end organ damage. And yet that's what is immediate. That's what's salient to them. And it's really important to recognise if they're going to drive the process, then it's got to be fueled by the things that matter to them. The patient's got to take the lead. And that also means that sometimes things are going to move slowly. But I would say, and I say this to student psychologists as well, rapid changes are illusory if they are not patient-driven. All right. So just wanted to branch out a little bit here into some of the theory. The trans-theoretical model's been around for a long time. I'm a little bit ambivalent about models, but sometimes they can be useful as heuristics. And I guess perhaps when I talk about stages of change or stages of readiness or the trans-theoretical model, I'd encourage you to distill something meaningful for you from this. It's useful as a gauge of progress and as a way of kind of locating the patient along a continuum, a way of deciding as well how are you going to pitch your intervention. So there's a different, depending on where they are along that continuum, you're going to have a different approach. So we've got 5 stages here that Prochaska and Di Clementi identified way back in 1977. We've got pre-contemplative patients. They don't see obesity as a problem. They don't see their weight as an issue. They're not really troubled by their health. And in each stage, what we're trying to do is see if we can move them to the next stage. So they can be assisted to move to a contemplative stage by rolling with resistance, allowing them to have their view, allowing them to have their thick body pride if that's what they have, not trying to go into battle and break those attitudes down, but you can just accommodate, be curious and inform, give them information about the health effects of obesity. Now, you've also got to be careful about what they're going to be receptive to, but if you're curious about them, then that permits them to be curious about you and what you've got to tell them. So it's about that idea of allowing their point of view and your point of view to coexist. And you may need to do a bit of work to kind of establish that norm within the consult or within that therapeutic relationship. Contemplative patients would see obesity as a problem but don't know how they're going to solve it. Maybe they feel it's in the too hard basket. They can be assisted to move to a preparation stage by giving them information about what works, by goal setting perhaps, but doing that in a very realistic, very contained way. And we'll talk a bit more about setting goals or developing action plans with patients in a minute. But giving them information, be constructive, be confident, and if you've got a good working relationship, then it'll be creative, and so new things, new ideas, new possibilities will start to emerge. Then, all going well, they might be ready to actually start to prepare something. They're ready to do something. They're ready to act, and really that's just about setting goals with them then. Make sure that if they're going to do something, that it's something that's constructive, that it's realistic, and that it's not going to be discouraging. It's not going to be another experience of failure that's then just going to cause shame and isolation. Patients who are in an action stage, presumably they've now had a couple of consults with you and they're coming back to tell you about the weight that they're losing. They can be assisted to move to a maintenance stage by giving them monitoring methods, and there was I think there was a slide earlier on, or there may be a slide in there somewhere, if I recall correctly, that just talks about helping patients to take control of their own health and giving them ways of doing that. Everyone these days every second person these days seems to have a Fitbit, and there are some pretty awesome apps out there. People love using those things. Patients who can afford it, there's some really amazing smart technology out there like smart scales, and that can be another way of, if they're feeling enthusiastic and they're kind of making things happen, then establishing things at that point that are going to last over time, establishing routines and patterns. Patients who are in the maintenance stage can be assisted to stay in that stage by providing validation. Well done, you did this. This all began with you saying that you wanted to do something about your headache. It turns out it was about more than just your wife. Relapse prevention advice is useful there as well. If a patient has had a success, take the win. It doesn't necessarily mean we have to then go on and occupy the entire, of Western Europe just because we've managed to seize one little bit of territory. Got to keep it realistic. And remember, if it's patient-driven, then it may be slower than we would wish it to be.
If I can just add one thing, Cal, before I
Sure.
go to my slide.
Yeah.
I just wanted to reiterate the point that we've heard about these 5 stages before in other clinical contexts, and I just wanted to reiterate that point because these stages essentially apply to all chronic health conditions, not just obesity. Because the last thing I'd like us to be doing is perpetuating the myth that this is a lifestyle choice or behavioural thing. So these stages of change and stages of readiness to take on healthy lifestyle habits and practices which we want them to have that are enduring pertain to any chronic health condition.
Well, not only that, Georgia, but Prochaska and De Clementi actually originally did a lot of their research in working with recidivism. And so this was about trying to help people who were in jail not reoffend. And it was about trying to find ways to actually get them to make changes in their life that would reduce the chance that they would reoffend and go back to prison. So it really is a very broad heuristic that can be applied to a lot of different situations. Change is the only constant, they say.
Thanks, Cal. Moving along, I just wanted to really make sure that we're all on the same page when it comes to talking about patients with obesity, just like we would with any other chronic health condition. We need to be using person-first language, and strongly believe that by doing so, it's a big step towards reducing the stigma that patients with obesity do experience and often cite. So I'm just going to illustrate a couple of the ones that are listed here. We don't talk about obese people, we talk about people with obesity. We don't say someone's fat. We say a person has excess weight or has class 1, 2, 3 obesity, etc. We don't say obesity is a lifestyle issue or a personal choice because we know it's not. The science tells us otherwise, and I believe our next webinar will be going into that in a lot more detail. But a more sensitive and empathic, yet still scientifically correct response would be obesity is a complex and multifactorial condition. And finally, for those who are not aware of the other therapies that we'll be covering in this obesity webinar series, whilst diet and exercise are important foundation stones, they play an important role in weight loss, but they are often the beginning of a multi-step and multi-combined approach to any chronic disease process. And I'll be illustrating that further in the upcoming slides.
Can I just add one thing there, George?
Yes,
people
please do.
First language, and this is the kind of pro-level aspect of people first language, and that is to appropriate the language of the patient that the patient is using. For example, with that case example that we mentioned before, where she's got this phrase, thick body pride. You can actually use that. You can, if the patient uses a term with you, as long as you don't think that they're using it sarcastically, then that's a mandate for you to use it with them. And sometimes, you can even have a situation where if they use a colloquialism with you, like I had a patient who often refers to her blubber, which is a pretty emotive term, but for her it's a very important word. It has a real significance and meaning for her. The first time she used it, I then was talking about it and I said, your weight, and she said, why can't you use that word? I use that word. Why can't you use it? Are you embarrassed by my blubber? And so it's almost like if they've used a word with you, if they've used language with you, that often can be a signal that you can use it back with them. Even if it feels a bit naff, sometimes it can be better than the alternative, which is to kind of use a more formal language, which then ironically can become a bit shaming as well.
Thank you, Cal. Now, I have been, whilst Cal's been kindly sharing his clinical experience and some pearls, I've been trying to get through some of the questions, and a common theme, and I did say we would be coming to it, a common barrier that many GPs cite is a lack of time. But let's firstly remember that time limitations are endemic of all chronic health conditions. It's not just exclusive to obesity management. Let's not forget that productive interactions can occur in relatively short periods of time. And if we can just hook them in with the initial discussion, it will then set the stage for ongoing conversation. And that will give us the opportunity to not only engage other family members, their spouse, etc., who will be integral in making sure that we can adopt and maintain some healthy lifestyle changes and compliance with any therapies that need undergoing. However, it also gives us as healthcare professionals the opportunity to also engage other members of our primary healthcare team, the clinical psychologist, the dietitian, the exercise physiologist, just like we would with any other chronic condition.
The family.
Oh yes, I said family first.
Yes, the community,
the spouse, yes, definitely.
Yeah,
the family, the spouse, sometimes it's community leaders, it all depends on the particular circumstances. I am cognizant of the time, but for those who want to learn more about this and to find out how they can actually achieve in just a handful of consultations, how they can actually have meaningful discussions with patients and just over a series of short series of consultations, break through some of these barriers. I really recommend this paper by Nicholas Forgione. I will disclose that I am one of the co-authors. But
Must be a good thing.
But it was designed by GPs for GPs because we're all suffering from the same time poor restrictions.
Yeah. Just my little addendum there as well is that continuity was one of my C's, and if you've got short consults and limited time and limited scope, then that just means that continuity becomes quite important. Chaining the consults together in the patient's mind, giving yourself some kind of signal or some kind of memory jogger in your notes or somewhere that's like, this is someone we're playing the long game with or whatever it might be. That's how you claw back the disadvantages, I think, of a brief consult. The other thing, when I saw your notes here and the slides, Georgia, I also thought about the patients who will say, I don't have time, I don't have time to exercise, I don't have time to weigh myself, I don't have time to prepare healthy food, I'm just so busy. One of the clinics I consult to is in a fairly affluent part of Sydney, and that's 99% of the patients who come through there, they're jet setting around, they're going to boozy lunches, they're being, they've got the one thing they don't have, they've got lots of money and they've got no time. For a psychologist, I don't have the time. What they're really saying to you is, I haven't worked out how to make it a part of my routine. And that's where creativity can be really useful. I love working with GPs particularly because I find GPs to be pretty creative folk, and that creativity is an enormous asset when it comes to coming up with interesting and quirky solutions. I had someone who was trying to work out how to remember to weigh themselves, and they actually got a set of scales that they could put in the shower, and so they would literally weigh themselves as they were getting into the shower or as they were getting out of it. Now I don't know if that affected the number, but it was a way for them to do it. So sometimes there's a bit of creativity needed to incorporate it into a routine, and once it's in a routine, then it's in there. So the next sort of slide that we're moving into is, I guess it's kind of roughly following some of that continuum around stages or readiness on the patient's part. And so now we might by now have a patient. We've been curious about them. We've used patient-centered language. We're using their lingo and their lingua franca to actually get a discussion going. They're now thinking about and wanting to make some plans about what it is that they're going to change. Maybe they want to incorporate some new things into their routine, and it might be time to set a goal. Goal setting always seems more daunting than it actually is, and in fact, much more daunting than it must be. It must be simple. It must be contained. It's great to set goals with a patient, but keep them conservative. Keep them patient-driven, and keep them time-limited. As a general axiom in any behaviour change, failure is the norm. I remember reading somewhere a long time ago that the typical number of relapses among people who are trying to quit smoking is 5. So people will try 5 times in their lifetime to quit smoking on average, and then they'll succeed on the 6th attempt. Now, I wonder what the standard deviation is there. 5 is the average. But what it means is you're going to have to fail at this 5 times before you have a lasting success. And I think that's important as well, is to be realistic. And being realistic means, if I can see that a patient's gearing up for something and they're really gung-ho, I'm not going to be pessimistic with them, but I am going to say to them, find words to talk about the fact that, this is just one battle in the war. And they'll say, don't burst my bubble. And it's like, well, I'm not bursting your bubble, but I'm saying there's a long road ahead of us, and it will be fantastic if this works first time. But let's also remember that, we're going to be working away at this for plenty of time. So let's keep it conservative. Now we'll also talk a bit about realistic degrees of change, specifically in the context of weight. But just to quickly summarise what's on that slide, we've got SMART goals, SMART goals, and I'm sure many of you are familiar with this concept. Specific, they need to be specific, anchored in something. How will you know if this goal has been achieved? That's what specific means. Measurable, how can you document that the goal has been achieved? Achievable is probably the single most important one. That's the whole goal has to be framed around what's possible. And I've made some very conservative and very, very effective goals with patients in the past, which is, for example, not to gain any more weight. Rewarding is also quite an important one. Ideally, the reward needs to be intrinsic to the process, and this also comes back to this idea that whatever it is that we're doing here is something that's got to be meaningful for the patient, and that the patient is driving the process. So the reward also needs to be a reward or a payoff that is salient to the patient. And time limited is important as well, not just because we're all strapped for time, but because the longer a goal process goes on for, the harder it's going to be to track and the less rewarding it's going to be.
Thanks, Cal. Now, those who've heard me speak before know that this is one of my favourite slides. It's probably just because I spent so many years in the UK that it just reminds me of my travels. I don't know. But on a more serious note, I actually, even though I've been in clinical practice like yourself for some years now in the obesity space, I still find that this is a big issue, because patients' dream weight and what our clinically achievable weight loss goals are with the treatments that are available today vary by quite a bit, and there's quite a big disconnect. And this is something that, as a clinician, even now, I struggle with, depending on the patient that I find in front of me. And whilst the majority of whilst the majority of patients who present for weight loss, in my clinic happen to be females, it's a difficult discussion to have with males or females, but in particular for women, because as you mentioned earlier, women often, I'm not saying only, but often will think that if they lose weight, they will feel better about themselves. And you and I know that, especially those with class 3 obesity who may lose a lot of weight, especially after, say, bariatric surgery, they're going to have a lot of loose, redundant skin. And if they can't afford to have that removed, if that's so what they want, but they just can't afford, then their self-esteem and their body image is also still going to be distorted, and they still won't be, inverted commas, happy, because yes, they've lost the weight and they're at a healthier BMI, so many aspects of their metabolic health has improved, but their body self-image may still not make them, inverted commas, happy. So often I'm quoted as saying to my patients, losing weight should improve your health and your function, but I can't look you in the eye and say that it's necessarily going to make you happier.
And I mean, I take a glass half full view of that stuff, because what it means is that the practitioner is going to get the outcome that they want without a huge amount of observed or dramatic change in the patient. Which I think then leaves some room for the patient to put some work towards an outcome that they're interested in. It doesn't have to be focused on body image or body shape. It can be focused on an enjoyable activity. If it is about getting the flight up to Queensland to see the grandkids, then that's a means to an end as well in relation to the weight loss that they might experience along the way. So I think there is a challenge there to bridge the gap between, not just between the patient's expectations and reality in terms of weight loss, but also the gap between what's meaningful for the patient and what's meaningful for the practitioner. But I think it can be bridged. I think it's just about bridging it with a therapeutic alliance.
Totally agree with you, Cal. And so that's a nice segue, because you said it also depends on what the clinician thinks and feels. And I'd like to thank Professor Colliguri, who's a well-known endocrinologist in Sydney, and who's also been involved with writing a lot of the NHMRC guidelines for diabetes, obesity, and a number of other metabolic health conditions. And what I want to illustrate from this slide, and I'm going to start from the bottom up, is firstly, as health professionals, we too may need a reality check, because we will use the example of diabetes as on this slide. We are told that as healthcare professionals, we should aim to get our patients with diabetes to have a HbA1c of less than 6%. But the reality is only about 5% of them achieve this. We tell our patients, look, I'll be happy if your HbA1c is less than 7%, that's a good thing. And about 30 or 40% of them will achieve this. And we pat ourselves on the back going, oh yeah, that's pretty good. But if a patient's got a HbA1c of greater than 7%, any reduction is beneficial. And that's something that we need to be cognizant of. And so when I now use the same concept, but looking at weight management, I want to illustrate the point, starting from the bottom up. Well, firstly, I actually should say, well, what is normal weight? Define normal, and that could be an evening webinar on its own. But let's just say, for argument's sake, they're defining it as a BMI of 25. How many healthcare professionals and patients are aiming for a BMI of 25? And is this achievable? And is it always desirable? Because we know in the elderly and certain other patients, it's actually not desirable nor necessary. But only a small percent of patients will actually achieve this. If we then look at those who have overweight, meaning BMI 25 and above 25 and less than 30, about 10 to 20% of them are the ones that are going to be able to successfully lose weight via non-surgical methods, Some may fall into the inverted commas normal weight, but many of them won't. But they still have improved their health, as I'll be showing you in the following slide. But once we have patients who have obesity, especially those with class 3 obesity, BMI over 40, I'm sure we all agree that any weight loss is going to be beneficial, not only from a metabolic point of view, from a functional point of view, but also from a psychological point of view. So my take-home message on this slide for us all is sometimes we as clinicians are setting the bench far too high. Benchmark of a BMI of 25 is not always necessarily attainable, especially for patients with class 3 obesity, not always necessarily desirable, especially for our elderly and those with other chronic health conditions. As you may be aware of the obesity paradox, we can talk about that another night. So I suppose the take-home is any reduction is beneficial, which is a great segue to my next slide. And I apologise, I thought all the arrows were going to come out at once. Okay, so let me firstly explain what we've got here. And I just want to make sure that we're all on the same page. So when the clinicians talk about percentage weight loss, we're talking about how much weight a person has lost divided by their starting weight, and then this is expressed as a percentage. So as we can see here on the x-axis, we have 0% weight loss, 5 to 10%, 15 and 20 and so on, okay? Then on the y-axis, we have a number of obesity complications. So health conditions that we know are associated with obesity. Now, I use this a lot when I'm consulting with patients. It's actually on my laptop. And prior to putting up the slide, I actually ask patients 2 questions. My first question is, why do you want to lose weight? And 9 out of 10 times I go, for my health. And I go, yeah, but what aspect of your health? And that's where I might get, I've been told I've got pre-diabetes and I'm scared of getting diabetes, or my knees ache, I can't keep up with the grandkids, etc. So I want something concrete. Then I ask them, how much weight do you think you need to lose to achieve that health goal? And I do this just to get an idea of, are we on the same wavelength or are we poles apart? And then I jot down the number, and then I go, okay, and then I put this slide up on my computer and I go, now, you said you were worried about, you've got pre-diabetes, you're worried about going into the diabetic spectrum. And I go, guess what? All you would need to lose with my help is 5 to 10% of your starting weight, and we can put you back into the healthier glycemic range. And I've got a calculator, I've got a big one because middle age is set in and I need the big numbers. I calculate for them 5 to 10%, and I say to them, this equates to 8 kilos or 12 kilos. And they go, oh, is that all? And they have a bit of a light bulb moment and a sigh of relief. And I'm sure you do this as well. I actually like to just have that silent pause and let them really absorb it. Yeah. Because they need to really take it in. And so my take-home message with this slide is a lot of the health conditions that we see listed here can be improved or prevented by a modest amount of weight. So it only takes 5 to 10% of weight loss, which translates to clinically meaningful improvement in a person's health and function. And so if there was one slide that I'd say, look, I'd love you to save on your laptop for easy reference, it would be that, because it's an easy one for us to be able to bring up to patients and help us to manage their expectations when we're goal setting.
Now this, I have to go back and have a look at that paper, but it's just such a useful, rich bit of data, and I mean, I can think of a lot of patients who would even be find just that slide interesting to look at. There is a paper that I think may have been one of the papers that was referred to in that Health Psychology Journal article. It's a seminal paper by Polivy and Herman, and we can provide the reference later on if need be. In 2002, they wrote a review paper called False Hope Syndrome, and they were just looking at patients who are trying to change a chronic condition, whether it's obesity, smoking, there were some other kind of things that they were trying to work on. And they just assessed patients' expectations and then looked at their outcomes. And what they find is pretty consistently, and this is whether it's in relation to obesity, it was particularly in relation to obesity, but there were other issues as well. Patients overestimate 4 things when they're planning a change or trying to do something about their health. They overestimate how easy it's going to be, or perhaps I should say they underestimate how difficult the process is going to be. They think it's going to be more straightforward than it is. They tend to underestimate the length of time it's going to take to bring about a change. So if they're going to lose 7 kilos, they may think that they can do that in a month. They also tend to underestimate the degree of change that is going to be necessary in order to bring about the outcome. So 7 kilos does feel achievable, and it probably is, but patients may still nevertheless not realise just what they're going to have to do. They might think, oh, I could do 7 kilos if I just go for a half an hour walk every couple of days and walk the dog a bit more, and I could probably do it that way. They will always consistently underestimate what they're going to have to do to achieve that. And then finally, and this is the kind of really difficult thing, and we have mentioned this in a couple of slides here, is being realistic about the outcome. Patients tend to overestimate how much better life is going to be as a result of changing this. Even if they do see improvements, even if, I as Georgia mentioned earlier, I do a lot of work with patients who are having bariatric surgery. And some of these people will halve their weight. They'll go from 200 down to 100 kilos, and they'll do it in, less than a year. And one of the things I see very consistently is that they're expecting that they're going to be dancing on rainbows and high-fiving everyone as they walk down the street, and it's nothing of the sort. It's a hard road, and losing that weight is of enormous benefit to them, but it's never quite as good as they expect it to be, and that's something that it's important to kind of cushion that blow, whether the change is a big one or a small one. Patients consistently overestimate how much better life is going to be. I like to say it's a zero-sum game. You're going to get benefits, but there's going to be things you're going to have to forfeit along the way. And that's what realistic goal setting is also about. It's about being realistic about how hard it's going to be, how long it's going to take, how much you're going to need to do, and how much better you're going to feel afterwards, which probably seems a bit bleak, but I guess it's about being, on the level with these patients so that then they're not kind of set up for a fall. Georgia.
Thanks, Cal. So, as with all chronic health conditions which progress with time, combination therapy is obviously going to be required at some point as the condition progresses. Now, there's no disputing that healthy lifestyle, which I define as nutritious, mindful eating and physical activity, are important and necessary foundation stones. Now, the other therapies that we can see here on the slide and which will be discussed in the ensuing webinars later this month and next month should be viewed as enablers, meaning they assist patients with obesity to adopt and maintain healthy lifestyle habits. But let's remember that everything that we discussed this evening and also during our obesity webinar series is going to be covered over a series of conversations, over a series of consultations by a number of health professionals, not just us. It'll be our practice nurse, it'll be the psychologist, the dietitian. It could be the receptionist giving someone a handout. Obesity management is a lifelong partnership between the GP, the patient, and the primary healthcare team, with the patient being in the epicenter. As is often the case with many other chronic health conditions, the goals will need to be reassessed and also adjusted as required. Weight loss, and more importantly, as we will hear in a couple of weeks' time at the next webinar, weight maintenance is not just about willpower. In fact, it's quite the opposite. And so roadblocks and setbacks, life events, they will happen over the course of time. And so as clinicians, we need to empower our patients. We firstly have to start with acknowledging up front that these are likely to occur. and then help them to develop strategies so that they can identify early on the symptoms, address them early on, and help patients overcome these barriers when they're encountered. Another potential goal that we can also set with our patients is self-monitoring. We know from the literature and clinical experience that patients with type 2 diabetes who monitor and document their blood sugar levels tend to have better overall glycemic control. So why should the management of obesity be any different? To me, self-monitoring includes a number of things. Weighing themselves, documenting what their appetite is like, the sleep patterns, because we know there's a strong correlation between disturbed sleep, especially shift workers, and distorted eating habits, their level of physical activity, their emotions and how they responded to these emotions, and to jot these down, whether it's in pen or one of the many apps that Cal alluded to earlier. We know from the American National Weight Control Registry that those that do this are more likely to maintain the weight loss that they have achieved and also enjoy the improved health outcomes that come along with that. Now, I've included this slide, which is a screensaver of the Department of Health website, which explains who is eligible for chronic care plans. This is a question we often get asked, and I think it's probably really a result of something that happened more than 10 years ago. And I do remember it being on the website many years ago where obesity was explicitly listed as an exclusion. But that was more than 10 years ago. So I'd like to draw your attention to the underlined. The eligibility for chronic care plans are, firstly, a person who has a chronic health condition. Chronic being defined as present for 6 or more months. Now, I have not yet met someone who's had obesity for less than 6 months. If someone has, please send us a message now, because I'd like to have a chat to you offline about it so we can write it up. Secondly, they would benefit from the input from a multidisciplinary team. We know that patients with obesity require help from a dietitian, exercise physiologists to make sure that they don't hurt themselves when they're trying to exercise, psychologists to tackle the multitude of related mental health conditions that can be a result of or a contributing factor to their obesity. It's the chicken and the egg, as Cal said earlier on. But what I really want to make sure that you take away from this slide is what I've underlined in yellow. There is no list of eligible conditions, nor are there any exclusion criteria. Another potential goal that we can as clinicians aim for our patients is to link them in with support groups, which can be either face-to-face or online. And we know from the literature that these result in better health outcomes for our patients. Moving along, I want to apologise that the services that I've got here on the slide are New South Wales Health specific. However, there are similar services in other states and territories in Australia. And I suppose this is a good opportunity for me to plug our RACGP Specific Interest Obesity Management Group, because I'd like to let you know that we have state leads. These are GPs that represent each state and territory in Australia who I'd like you to think of as your go-to person. So if you have any questions as to what local services are available, how do I find a doctor who has a specific interest in obesity management, or are there any bariatric facilities in the public healthcare system, which dietitians are aware of VLEDs and other obesity-specific dietary interventions, they'll be able to point you in the right direction. The RACGP is committed to supporting GPs and their primary healthcare team, and the vision is to have this information available online, hopefully in the near future when the IT system is further developed. However, let's not forget what we already have. We have some excellent RACGP resources, such as the SNAP guidelines. Remember, we want to engage our patients in the management of their condition. But we also need to make sure that we train and upskill our clinical staff, and that includes also the admin staff. They need to be aware of patient first language. They need to be aware of what resources are in the waiting room. They need to know how to respond to comments like, "I can't believe the nurse weighed me. Why did she do that?" Whereas if the admin person says, "Oh, we do that with everyone, just like everyone gets their blood pressure checked," and we normalise it, then I think we'll be breaking down some of the barriers.
Yeah. I mean, I think there's lots of openings there. Even if a patient is frustrated or unhappy about something, there's opportunities for curiosity there too. Are you surprised? Wow. Okay. So what? Did you not know that weight was a relevant thing, diagnostic thing for lots of other conditions? It's a really quick and easy way. So that education is also making sure that everyone is thinking cross diagnostically about some of these things too.
Totally agree. Now, the importance of establishing an understanding, empathic and non-judgmental therapeutic relationship with our patient has been emphasised more than once throughout this webinar. As with all chronic health conditions, regular follow-up is critical. Now, one of our Obesity Management Network members, Dr. Sturgis, published a paper last year on this very point, and I highly recommend you read the paper. But the key points are, firstly, and most importantly, as Cal mentioned earlier, we need to make sure that we adopt a patient-centered approach. Secondly, ongoing care is vital. Just like a patient with type 2 diabetes has their GP, they've got their nurse, they've got their diabetes educator. Patients with obesity also need to have someone. They need to have their go-to person. It could be the GP, it could be the practice nurse. They need someone that they can regularly check in with and, inverted commas, go to if they have encountered an obstacle or a setback, as we discussed earlier.
Georgie, can I add something to that just quickly?
Yes, please do.
I've just, as you've been talking, I've also been having a bit of a glance at some of the questions and comments that are coming in, and they're coming thick and fast. But there have been a few questions there about how we might adjust or if we might take a slightly different approach to some of these things, like goal setting or engaging with patients, obese patients with obesity, who are adolescents or young people. And I just wanted to I think that this slide is kind of pertinent there. I think that some of these particular kinds of aspects of the engagement are quite relevant. I think that adolescents and young people would often be down that pre-contemplative end of the spectrum, and that's not necessarily because they're kind of slackers, but often it's because they also have that external locus of control, because, as you know, the nature of adolescence is that it involves sort of renegotiating your independence from your family. But fortunately or unfortunately, family relationships are absolutely central, for better or for worse, whenever we are working with behaviour change, particularly health-related behaviour change in an adolescent. Family relationships are key. So to come back to a point that I made earlier on, it may not necessarily be about trying to bring about change or driving change. It might just be about setting the scene for change. And that means, one, that ongoing relationship, if they're coming in and you're seeing them, if they're being dragged in by their mother because they've put on another 10 kilos or something, to establish a relationship with them that is going to last over time. Make sure that, see if you can get an ongoing relationship going with them. They may be eager to learn. They may be more interested in information at that early stage, more interested in that than they would be necessarily in being given more homework to carry out or things that they have to do. They may be more interested in ideas or information. The internet is a really, really salient point of engagement for young people, and so send them to the internet, get them to go and go and look those things up. But ultimately, any change that is going to happen, if they come in and they say, I want to lose weight, I want to do stuff, the family really needs to play a part in that. Too many times I've seen really, really fantastic, motivated, admirable young people who are trying to do something about their health, and the family will sometimes will even actively sabotage that. So for an adolescent, the family relationship is still such a huge part of their life, and I would argue that it's going to be very difficult to make big changes with them without bringing the family along for the ride.
Thank you, Cal, and I totally agree with what you said. Now, you might laugh, but this caricature is really of me each time we get a new group of medical students that, or registrars that come to our unit and to our clinic. And I explain to them that there's only one word that our department does not accept, and it starts with F. And I'm not being cheeky here.
Yeah.
And that word is fail. Okay? Do we ever say that patients with diabetes fail oral hypoglycemic therapy and therefore require insulin? No. Do we ever say patients with cancer who've come out of remission have failed? No. This is a natural consequence of a progressive condition.
It's the norm.
It's the norm. It's what we expect.
Relapse is the norm. Yeah.
Exactly. So if we make sure that we, in our early encounters, it's not going to happen in the first consult. The first consult is going to be establishing rapport and opening the dialogue. But in the course of the numerous consultations that we'll have, as long as we reiterate the point that it is a chronic and progressive condition, and that we do expect and anticipate periods of relapse and remission, then we're all on the same page.
Yeah.
But fail is a dirty word in our clinic. Just like we have with diabetes therapy or hypertension therapy, we'll say patients respond well to a particular therapy or partial responders to a particular therapy. That's exactly the same when we're talking about weight management and response to different therapies. No one fails a particular diet. It just their body did not respond to it. Or no one particularly failed a particular medication or an operation. It just wasn't the one that their body was going to respond to.
Yeah, I mean, shame is such a big part of this area of medicine, and in the same way that a person with diabetes is going to see problems managing their blood sugar as a prompt to actually go back in to see the endocrinologist or go back in to see the doctor. It's the opposite with weight. If I put on more weight, then I'm failing. It's not working. This isn't working. And that's actually a trigger for them to isolate and to back away. So it's really, really important that the way we're communicating is actually saying, I want to know when things are hard. I want to be involved when things aren't going the way you want them to. That's the time when I need to get involved. It's not the time to back away.
I totally agree, Cal. What I say to my patients, over the course of time, you develop a rapport with them. I say to them, it's lovely to see you when things are going well, but it's when things aren't going well that I want you to phone a friend.
Yeah.
And I go, and I'm that friend.
Yeah.
Our clinic is your friend.
Yeah.
So
I say, I call myself NRMA roadside assist.
Okay.
In Sydney.
I like that.
Yeah.
Do you mind if I use it? I actually say, like it's one of the games, I go, you could ask the audience, it's 50-50, but I'd rather you just phone a friend because you know what you're getting. But I like your NRMA system analogy too.
Or RACV, or whichever state
depending, that's fair. So let's just recap. Obesity is a serious health condition for both the individual with obesity, but also for their family and their carers. Let's not forget them because they're the ones that are offering the help and support. And so we need to also link the carers to appropriate services. I've got here two services. One's New South Wales specific, one is Australian-wide. So I think, they're good resources that you can tap into. And I want to reiterate that the RSAGP is committed to both the primary prevention, but also the secondary, the important access to evidence-based medicine as a priority. And our President, Bastian Seidel, has always talked about following the evidence and practicing evidence-based medicine, and that's what we're advocating for. We want to address that inequity in access to the service provision that we mentioned earlier on. And by offering patients and their carers support, that's one way that we can try to help address things. Another thing that we can also do is to help dispel some of the myths that are in society, because it is these myths that are basically perpetuating the stigma, the shame, the bias that is inherent in community, but also, sadly enough, among some health professionals as well. And so, though the science behind weight management and obesity and why maintaining weight loss is difficult will be explained in a fortnight's time, and I strongly encourage you to join us in for that webinar, what I would like to remind you is that obesity is not a choice, nor is it a failing of willpower. And as a GP, what your patient with obesity wants to hear is, I understand your condition and I'm here to help. And if this is done in a non-judgmental and empathetic manner, then I think that will be the beginning of a therapeutic relationship that should be lifelong.
Mm-hmm. Yeah.
What do you think, Hal?
Yeah, I mean, I think I tend to see people who are often at a more fragile in their presentation, and so I tend to I say that phrase quite often, but I say I want to understand your condition, and I'm here to help, or I need to understand your condition. And I think that's really what it's fundamentally about. It's about the curiosity and compassion, but then there's that confident approach. It's like, I want to get involved here. That's what I'm here to do. That's my job.
Thank you. I sometimes have patients that come from rural New South Wales to see me, and then we do a shed care program with their local GP. I have others who just come from a couple of hours away, so they're still in the outskirts of Sydney. And so they can't necessarily come and see our in-house psychologist. And I thought I'd share this for me, it's a pearl. I initially didn't know where to go to, and so I asked our clinical psychologist, how do I find someone like you that works here or there? And this is a nice website whereby you can put in, when we say the problem area, the area that the person needs help with, whether it's body image concerns or weight concerns, and if they prefer a particular language, the postcode, and I know the screensaver doesn't show it, how many kilometres the person is prepared to travel, and then it just starts to show you a list of accredited clinical psychologists who have a specific interest in managing patients with obesity and the related comorbid complications.
Yeah. And the only thing I'd add to that is that from time to time I'll get a phone call from someone because I'm on that directory and I can't see them, but I can always recommend someone who can. So sometimes it's just a starting point for them.
That's great. Thanks, Cal. So that comes to the end of our talk. We have about 10 minutes, so whilst we give you the opportunity to jot some questions, I just wanted to tie everything really together. We've identified that obesity is a chronic and progressive health condition. It is not a lifestyle choice. It's not a failing of willpower. It's incumbent upon us as healthcare professionals to open the dialogue, start the conversation, and as has been raised by some of the comments from our questions thus far, there will be patients who are not ready to have that conversation, and that's okay. We just have to be cognizant of and respectful of their wishes, and if they don't want to talk about their weight, that's okay, and just say something such as, would it be okay if at a later date we discussed your weight and in particular how it impacts on your health or your sore knees or the blood pressure or the whatever they came in with that particular day, so that we can hook them in and link it. And that's just really keeping the door open for possible future dialogue.
Yeah, we've identified that this is a chronic condition, which means that it needs a long-term response. It's not necessarily about changing things. It's not about even necessarily about the patient changing things. It's about setting the scene for change to occur. I sometimes say to patients that losing weight is a little bit like trying to get a better night's sleep. You can't actually do it directly. You might have to just set everything up so that it's more likely to happen. There's also, we've said a lot tonight about language, about the language you use with the patient, about language that you use with colleagues, with allied health professionals. And that isn't just about words or nomenclature or de-jargonizing things. It's about engaging with the patient using their own language. And it's also about being clearer conceptually. There's health, there's weight. Those two things are not the same. There's things that will change, but it isn't necessarily the case that it's all kind of cut and dried. We're just trying to get the kilos to drop away. So sometimes it's just about opening these issues up with the patient. That's what we mean in the learning outcomes. We talk about open and positive communication, reducing stigma. When we talk about engaging patients in self-efficacy, what we're really talking about, I had a patient the other day, and he was an army man, and I said, look, you're going to have to be the general here. You're going to have to actually lead us into battle. You're going to have to be the one that sort of tells us which way we're going to go and what our strategy is going to be. We'll give you the intel that you need, but you're going to have to drive this process. And that's really what self-efficacy is all about. Even if that means that things don't move along as fast or as dramatically as that we would, or the patient would want them to, that's what realistic change is all about. And if the patient's driving it, then it will be real, even if it's slow. And then also we've given you a bunch of data and some research studies that put some numbers around what's realistic, what's realistic for patients to achieve, what's meaningful in terms of health, but then also recognising what's going to be meaningful for the patient if they're going to be the ones who are driving change, then the outcome's got to be one that's meaningful for them. They've got to be the one to decide where the battle's going to be fought and if we've won it. So we've covered off a few things. I can see there's a whole bunch of questions coming in there. Georgia, is there anything we want to speak to there?
Since we've got a few more minutes, if that's okay, there's one that I thought might be an interesting one to hear what your thoughts are. How does the doctor's own weight affect their advice, or how does the doctor's own weight affect how their advice is perceived or accepted?
Yeah. I think you've got, maybe I'm going to do the glass half full thing here again. I think you've got the best of both worlds there. If you as a practitioner, if you're overweight, if you're obese yourself, then I think that opens the door for you to be able to talk much more readily with a patient about it, as long as you're comfortable to acknowledge that you're speaking kind of from the heart. So I think that the benefit there is that you may find it easier, and the patient may find it easier to be open with you, and they may feel that they're less judged. I'm not sure. I don't recognise the questioner, but if you yourself have gone through processes of weight management and experienced that axiom of relapse is the norm, then you will know how hard it is, and you can then, from a very valid and compelling position, talk to the patient about how this is a long process. It's a war of many battles, and that there will be setbacks and disappointments along the way. So I really don't think it delegitimizes you. I think quite the opposite. It actually legitimizes your capacity to speak from an authentic position to the patient. I guess that's the whole idea here is it's about recognizing what's going to be meaningful and relevant for the patient if they're going to be the ones who drive this. Having said all of that, it also kind of highlights the fact that, it's the patient's process. It's the patient's problem and it's the patient's process. And so they're going to need to be the ones who identify what it is that they want to change. If you're kind of sitting there, with a weight issue yourself, then it's important not to, I guess, let that be the template for what it is that they need to do, either a template for what it is that they need to do or a template for what it is that they shouldn't do. It still needs to come from them. So it's useful in the sense of that, you're going to be able to engage more readily, I would think. But it also still comes back to the fundamental task, which is to set the scene for change by putting the patient at the forefront of the planning process. What else have we got there?
Do we have time for one more question? Yep, okay,
cool. For another question? There's been lots of them, by the way, and we've been looking at your comments as we go and tried to respond to a few of them.
We've tried to
there's
respond,
been a lot of active discussion out there,
which we thoroughly encourage and
appreciate.
And please don't panic. We will be able to any questions that are not answered now will be answered in the upcoming weeks. Okay, so I suppose the last one is, let's see, sorry, just trying to make sure that it's something that we haven't already covered. Okay, I work in education and advocacy, and there has been fairly explicit advice that we should refrain from including obesity, including a Medicare representative at an RACGP conference last year. Sorry, I might have to answer that one offline, sorry. I suppose one of them would be, and something that Cal can do at a later date, maybe some of the apps or some resources that you think might be useful for GPs to have at their fingertips to be able to guide people, because going on what you said earlier, especially with adolescents, but also young adults, and it's not ages. I've got 50-year-olds who are very IT savvy and love their apps. Sending them to the internet can sometimes be good, but sometimes it can be bad, because then they come back in saying, I've read Wikipedia and I think I know everything about my health condition. So I suppose it's about responsibly guiding them to some good websites.
There are reviews online, and I will I'll encourage patients to go and do their own hunting. MyFitnessPal is one that everybody seems to love. Dietitians, patients, practitioners, surgeons, bariatricians all seem to really like that one. It seems to be pretty comprehensive. It integrates quite well with devices and things like that too. So that's one of the ones that I guess would be out there. But again, the internet is a vast and it's a vast resource of mixed reliability, but I think it's a useful foil for discussion between you and the patient if you're still working towards that stage of action and in that preparation process. Then it's great if the patient is willing and able to go and do their own research.
Excellent. And on that note, just before we finish, I'd like to bring to your attention the National Guide to a Preventative Health Assessment. And, sorry, my glasses just fell off. Sorry, my apologies. Let me start again. So just before we finish, I would like to bring to your attention the National Guide to a Preventative Health Assessment for Aboriginal and Torres Strait Islander people, which is now in its 3rd edition. The guide advises on activities that can help prevent diagnosis, detection, to detect early and unrecognised disease, and also to promote health in people of Aboriginal and Torres Strait Islander communities, whilst also allowing for local and regional variations. Now, the RACGP has worked in partnership with the National Aboriginal Community Controlled Health Organisation, which I understand is the peak Aboriginal health body in Australia, to develop this resource for health professionals. And so I really encourage you to have a look at it. And finally, I would like to now take the time to thank our sponsors and our advertisers, as you can see on our screen. We really appreciate the support of their support for the obesity webinar series, and this is the first of a series of 5. I'd also like to thank my co-presenter Cal and also the RACGP team, who did the very hard behind-the-scenes work to make sure that the organisation leading up to this event, but also the delivery of this webinar tonight, ran as smoothly as possible. And finally, I'd like to thank you all for joining us tonight with your great questions, for participating, and we look forward to joining us again at our next upcoming webinars, as you can see on the screen. Like we said once again, the questions that haven't been answered will be emailed to you in the near future. Thank you for joining us, and have a good night.
Thanks very much.